Hi, this is Elliot Fishman moving over here. And welcome to our Facebook Live. Today is Thursday, I think it's July 8th. I hope everybody is having a great start to the summer. Hopefully, this COVID Delta variant will not be too problematic. But anyway, we got our new fellows. They're starting. I'm on call starting Saturday. Oh, happy day! But hopefully, this will be a great weekend. This is the beginning of a great summer and a great year. I know many of you are sweating like crazy. I know our friends in the Northwest, Portland, Seattle area, it's just been terrible temperatures. So hope everybody's keeping cool, and our friends in Florida with the storms, the Hurricane Elise or something like that, something with an E word, not Elliot, but the storms are going through and everybody is okay. So this week, the topic I chose was on pediatric pancreatic tumors. So I want to talk to you a little bit about that. And as you know, at Hopkins, we do lots of pancreatic tumors. We're doing almost 500 Whipple's procedures a year. We just a very big pancreatic service going back. Dr. Cameron started 30 plus years ago, and it's evolved. It's interesting. I give conference. I mentioned to you this before every Wednesday, and the third Thursday I show you cases. But one of the things I've been showing is a lot of SPEN tumors, solid papillary epithelial neoplasms. SPEN tumors were exceedingly rare. I had a few cases here and there, but lately I've seen a lot of these SPEN tumors, and then I started reading a little bit more, and someone made the point that SPEN tumors are roughly 4 times in frequency than they were 20 or 30 years ago. Maybe it's better imaging techniques, but it just seems like there's more cases. And I've been showing them in conference. So when you think about pediatric tumors in the pancreatic age group, I always think of SPEN. That's what I see the most. But there are a number of possibilities. And so if you looked at a differential diagnosis list, we typically would talk about SPEN tumors. We talk about pancreaticoblastomas. Now, when you think about the classic tumor, the word blastoma, hepatoblastoma, that's hepatic tumors in children, and pancreaticoblastoma, a very uncommon tumor, but in children. There's a thing called islet cell adenomatosis. Islet cell tumors do occur, particularly insulinomas, though they're rare. We see pseudocysts and true cysts. We do see cysts in things like cystic fibrosis, where you can see multiple small cysts, cystocytosis, or one large cyst, which can occur. Though most of the time in cystic fibrosis, in classic CF, you have fatty infiltration and replacement of the gland, and you simply see the patient's pancreatic duct. We then talk about cystic neoplasms because things like serous adenomas can occur in childhood, though it's pretty infrequent. And then we talk about metastasis to the pancreas, which is really, I never thought about that, but when I read some of the articles, they made the point like neuroblastoma can invade in. That's always a possibility. And some of the other sarcomas can metastasize to the pancreas. Rhabdomyosarcoma might be one of them. Now, if we stick with the two big ones, pancreaticoblastomas are typically large, cystic and solid tumors of the pancreas, often very vascular, occur between age 2 and age 10 typically. Aggressive tumors commonly will metastasize. Now the one, particularly when you're an adult person, adult body imager, is SPEN tumors. Now SPEN tumors are kind of classic. SPEN tumors very nicely are typically female, probably 90% over male, and they're anywhere between age 10 and age 30. Now sometimes we've had patients in their 50s, and I've also seen patients like 8 or 9. It's an interesting tumor. So the smaller ones, the smaller SPEN tumors, can be solid masses, very well defined, may not cause duct dilatation, be it pancreatic or common duct. Statistically, most SPENs are in the tail of the pancreas, though we've seen a whole range of things. We also, with SPEN tumors, I mentioned the solid mass, We then have, just like it says, cystic and solid, lesions that are mainly cystic, often with enhancing rims. We also have lesions that are cystic and solid, a range of appearances. If you go into our teaching file, you can see a lot of cases of SPEN and the range. And I'm finishing up today this talk on SPEN tumors, which will be recorded maybe this week. And then that means it'll be put up sometime, just because we do things in advance, we put up sometime around late September. So you will be able to see a couple talks on SPEN tumors, and I'm going to show a lot of cases in that talk. I have almost the talk perfectly finished. I'm just trying to adjust a few little things in terms of the sequencing of the talk. It's interesting in terms of calcification. You know, there are many things that can calcify. Serous cystadenoma, central calcification. Dense coarse calcification in serous cystadenomas can occur centrally. Islet cell tumors can calcify. We know adenocarcinomas essentially never calcify. Every once in a while it seems that perhaps there's an adenocarcinoma that calcified, but it's probably an adenocarcinoma arising in an area of chronic pancreatitis. SPEN tumors, on the other hand, commonly calcify. Sometimes it's thin rim calcifications. Tumors that have rim calcifications would include mucinous cystic neoplasm, or MCN. Often has a curvilinear calcification. With SPEN tumors, often you have a lot of dysplastic calcification. Maybe the rim, but maybe centrally as well. Maybe there's a bunch of linear calcifications, linear lines. So you could have minimal to significant calcifications in patients with SPEN tumors. That's one of the things that might help you in that specific diagnosis. SPEN tumors can also be very vascular. 95% of the time, SPEN tumors can be resected without any nodal disease or any liver disease. About 5% of the time, they are aggressive with good liver mets, either at presentation or later on. Typically, with SPEN tumors, you can do resection, negative margins. Patients will do very well, long life, and there's no chemotherapy. Other cases, the tumors are locally aggressive. There are maybe liver mets, and then you need chemotherapy. So that's a couple of the tumors. And before I go further, let me just say hi to some of our people. Alberto in Edinburgh, Texas. I'm not sure where that is. From Carlos in Mexico, and Manaverdra, who's from Nepal, and I think we see him almost every week, which is great. Lily put up where in the teaching file you can go look under pancreatic masses, so that can be a very a good place to look. If you remember, in our teaching file, we have hundreds of thousands of images. The easiest thing you do is if you go to teaching file and you just type in SPEN, it'll take you and show you all the SPEN cases. We have a really good search function in the teaching file that I think is very valuable, so I would recommend you use that. And then what else? In terms of SPEN tumors, I think I mentioned, when they're teenagers and they're women, it's pretty easy. If you tell me a patient has a pancreatic mass and they're 19-year-old female, I'm going to see a SPEN tumor before I even look at the images. But as I mentioned, we are seeing them in their 30s, and their 40s, and their 50s, and so then could it be an MCN? Could it be a serous cystadenoma? Could it be almost an adenocarcinoma? With the coarse calcifications, could I be thinking about a neuroendocrine tumor? So it's not always as easy in older patients, older being over 20, but again, we are seeing those more frequently, so it's something you need to think about. I think it's particularly helpful if you see calcifications, particularly linear calcifications, extensive calcifications. At least put SPEN in the differential diagnosis. That'll help them in terms of managing and thinking about the case. So it is something that does become of some importance. Now, in terms of pediatric patients, the question is, what's the best imaging modality? Ultrasound works very well, MR works very well, CT works very well. Obviously, we like to minimize the dose in very young patients, so perhaps you can start off with an ultrasound, but at the end of the day, I think when you start doing surgical planning, when you want to look at vascular mapping, look carefully at the liver, CT tends to be the gold standard. And again, we can do with good control over radiation dose, we can do relatively low dose studies. So that becomes important as well. You need to know make sure your protocols are well done. We do have good CT pediatric protocols on CTisus. Remember, as Dr. Dorst told me many years ago, children are not little adults. So you need to have the dose appropriate for children, not just a low adult dose. And here I learned something new. Alberto says that Edinburgh is the most southern tip of Texas, so it must be mighty hot down there. Megan, thanks for the recommendation. Alberto, Rio Grande Valley, I can't imagine how hot it must be there. And then there's John from Body CT telling me there's 48 orders pending. John, I'm on this weekend. If you can get this stuff done before Saturday, I would appreciate it. Those of you who know that the volumes, I know at Hopkins, surely, inpatient and outpatient, and probably at your hospital as well, the volumes are back to normal. I think not only are we pre-COVID normal, but we're actually more cases now than post-COVID, than we were pre-COVID rather. If you're looking for a job as a technologist, probably everyone will say the same thing. You can go anywhere. We are looking for people at Hopkins, the outpatient centers, the hospital, the ER, the cancer center. You tell us what you want, we'll figure it out. But one of the real challenges in radiology these days is technologists. I think particularly in this post-COVID era, some people have stepped back, some people are changing jobs. I think it's really, we've always been great believers in the single number one factor for us doing great CT or great ultrasound, great MR, is the quality of the technologists. So it's very important for us to have really good technologists. I've also always said that even if you have a good tech, till they're out about 2 years, they really don't have a great feel for how to do things, and then they really get great. So there's a learning curve, even if you're good and getting started. I think the same thing would be true with physicians. You can go to a great program, be really, really good, but I think it takes a couple of years for you to hit your stride. When you kind of have more experience on your own, you kind of learn a lot more, know a lot more. So whether you're a tech, physician, nurse, I think almost any job, it takes a little bit of training internally to really get good. Particularly every place tends to be a little bit different. So that becomes very, very important as well. So if anyone's looking for a job, I don't want to be recruiting people, but if anyone's looking for a job, you can email us. Becky Ryan's our chief tech, or you can email me directly and I'll send it to her if you're looking for a job. Or you can call up, email John Biacchino. John's from Staten Island, so he'll tell you the truth. People from Staten Island tell the truth, I think. Let's see, Lydiana's saying hi. Lydiana's out in Palo Alto and San Francisco. So hope she's doing well. And I think that area is having nice weather now. I know for a while San Francisco and the Bay Area was super hot. Now I think it's a little bit more back to normal. So let's see, what else can I tell you about pediatric tumors? In terms of protocols of the CT, I like dual phase imaging. Again, the arterial venous is critical for vascular mapping for preoperative planning. Laparoscopic surgery is used commonly in pediatric patients. So it's very important to really get a good quality study. Again, fast studies, patients being cooperative are all very important. And again, minimize the dose, but do a great study. You don't want to do the study twice. I always make the point that the worst thing is to do the study twice. Now, I'm just leaning over here. Here's my computer, which has fallen asleep. I did want to look, and now, as I told you, I'm going to give you a lecture about this, but let's see what else could I tell you. So you see, I mentioned spend tumors of the pancreas, what you need to know. There's the talk, almost finished. And as I read through some of the stuff, it's interesting. There's one article from a tertiary care center, 23 children, over a 10-year period, 12 had SPEN tumors. So you can see, so 12 had SPEN, 3 neuroendocrine, 3 lymphoma, and 1 had cysts, and the rest had METs of some type or other. So pancreaticoblastoma, most common tumor in childhood, but again, it's pretty rare. They can be described with Beckwith-Wiedemann syndrome as well, which is pretty unusual. In terms of neuroendocrine tumors, I mentioned that they can be functioning. Islet cell tumors functioning, you really about, gastrinomas can occur, VIPomas can occur, but really it's insulinomas that are the ones we most commonly see. They're very challenging because insulinomas average about 1 centimeter in size, so they can be important. I think I mentioned briefly, but you also can see lymphoma of the pancreas, but it's rare for us to see lymphoma only involve the pancreas. There's usually multi-organ involvement. I showed a case at conference yesterday. It was pancreas, it was spleen, there was some adenopathy. So that's very, very important. In terms of some of the other features, the interesting thing about SPED tumors, I mentioned, about 10% or so are malignant and become problematic. Most will do well, 95% of the time. Patients will do very well in the short term. In terms of imaging, I mentioned they can be solid looking, they can be cystic with solid components, they can have rim enhancement, they can have septations. They have calcification centrally or peripherally. So there's such a range of appearances. Sometimes the lesions are at the edge of the gland and they're a little bit tricky because you can't tell is it pancreas or not. Once patients are in their 20s or 30s, it's a little bit more tricky, the differential diagnosis. And I've seen a case a couple weeks ago where I think you'd be hard pressed to say if it was a SPEN or was a serous cyst adenoma. It ended up being a SPEN, but it was a difficult case. I mentioned about calcifications, mainly centrally, but also peripherally, dystrophic calcifications. So a range of appearances that I think do make SPEN tumors challenging. Here's just a good example on my computer of one in the tail of the pancreas. Now, it's not good to show computers like that. I will tell you also, I've been doing cinematic as a way of looking and trying to better understand the septations and the enhancement and the whole process of SPEN tumors. Not quite been successful yet, but I haven't given up yet. And as I mentioned, the SPENs can be from 1 centimeter to about 10 centimeters, no calcifications to extensive calcifications to punctate calcifications. So lots of variable appearances. I think there's no magic in that. And again, when you think about from the differential side, 90% are female, 10% are male, and it's a younger population, okay? So that kind of covers pediatric tumors. I think that one of the things we will try to also focus on, and maybe future talks, some of the pediatric tumors in the kidney, whether it's medullary tumors that occur in sickle cell patients in the kidney, younger patients, or it's Wilms tumor in childhood, or it's chromophobes, or any of the various renal tumors that you can see. Now, if anyone has any questions, this probably is a great time to ask me questions, because if not, you will have to not be able to ask questions because I'll close the session. But hopefully this is helpful. Again, pediatric patient, think of SPEN, think of pancreaticoblastoma. If there's multiple other organ involvement, you got to think about lymphoma, you got to think about metastasis. Other tumors, from neuroendocrine tumors to islet cell tumors, are all going to be relatively rare, but it's something you do need to think about. So with that, I'll say hi to all my friends wherever you guys are. We are making great progress on CTisus, be it on Instagram, Lily's doing new stuff there, and on Facebook we're doing new stuff. We're doing new apps. In the next week you'll see 4 new apps, iPearls, iQuiz, and iLectures, all with updated versions in the Apple Store, and we're announcing those. You'll get an official announcement, but I think it's just a matter of by next Monday, they all should be approved by Apple. We're making some last minute changes, and then it takes Apple a few days to get it going. So, but we're getting there, So with that, oh yeah, the question about Alberto, multi-phase in pediatric patients. I think the issue is, obviously you like to do single phase in every patient, getting peds, but peds especially. But sometimes when you really want to get a quality study, on pancreas is a good example, where you want to know the vascular map, you're going to have to do a dual phase study. You don't necessarily need to scan the entire abdomen dual phase. You can do liver and pancreas. So that's about half the abdomen, and then maybe that's all you need to do. Again, make sure you use Alara principles. Make sure you know how to use your scanner, and make sure your scanner has pediatric protocols that are sized correctly for children and not just simply low dose adult protocols. So hopefully that helps. Anyway, I wish everybody a great day and a great afternoon, and I will see you later, alligator. Bye.